can you please, for those of us who don't know, introduce yourself to our audience?
Well, thank you so much for interviewing me today. I know you traveled to Houston, and I'm very appreciative. So, my name is Elias Jabbour. I'm a professor of medicine at MD Anderson Cancer Center. I'm in leukemia department, and I lead the ALL section in my department. I've been here for 21, 22 years. I'm originally from Lebanon. I'm French educated. I went to do complete my medicine in France and my residency and fellowship. And I came to Houston. I did my fellowship at MD Anderson, enjoying this amazing place since 2007. I've been here since then.
Amazing. So, I just want to talk to you a little bit, first of all, about these TKI, TKIs, these tyrosine kinase inhibitors, and just personalized therapy on CML in general.
The outcome of CML has drastically changed. When I started my fellowship and a little bit before, the outcome was bad, and the survival used to be 6 to 7 years. And only those who are lucky, who are young, who have transplant option and get transplanted, survive. Today, with the tyrosine kinase inhibitors available to us today, a patient with CML can expect to have a normal lifespan. So when I see somebody in the clinic, I tell them the bad news: you have cancer. The good news is you'll live normally. And not only they live normally today, we're able to stop therapy after a certain time. Essentially, if somebody responded and maintained response for 5 years, we're today able to stop therapy and patient can have a normal life. So this is a major accomplishment, and today we have a multiple tyrosine kinase inhibitors, and all are great.
Mm. So, some of your research has detailed both BCR-ABL dependent and independent mechanisms of TKI resistance in CML. How often do you encounter BCR-ABL independent resistance in clinical practice, and what are the most effective strategies you think for managing these
Well,
cases?
let me rephrase it. Resistance is not something common. So if a patient is compliant and taking his or her medicine, they should do well. We know from large database, mainly in Europe, in Germany, that resistance is around 1% per year. So 99% of the patient will do amazingly well, and 1% will be unlucky to have a problem. Now, if you take intolerance to having adverse event not well managed, that will move it to 2.5% per year, but not more than this. Now, when it comes to resistance, half of them are driven by mutations in the kinase domain that will prevent the binding of the drug to the target, while the rest are independent, and we do not know much about them. But this is something very rare.
Mm, amazing. So, with this increasing use of next generation sequencing for mutation profiling, how do you recommend, or what is your approach to integrating these results into things like routine decision making for patients with suboptimal
Well,
TKI?
for people listening to me today, let me be clear. When we talk about uh, NGS, there's two kinds. We're looking at the kinase domain mutations, or we look at the myeloid mutation outside the kinase domain. What practice today is to look at the kinase domain mutations by NGS or PCR. Today, there's no indication to check for mutations at the baseline or in somebody responding. We only check for these mutations in somebody losing his or her response or not responding, because then if we identify a mutation, that can dictate the choice of next line of therapy.
Mm. And then are there guidelines or specific kind of resistance mutations or patterns that prompt maybe earlier consideration?
I mean, if a patient not meeting good milestones, and resistance is defined by the lack of achievement of a transcript below 1%. Anything above 1% for me is resistance. Any patient who do not achieve at 6 months transcript below 10% is resistance. At 1 year, 1%. Now, anything underneath these levels is not resistance. So, for example, if somebody had a PCR at 18 months where the bcr-abl cell level is around 0.5%, this is not something to worry about. Only I would worry about it if the level remains above 1% beyond 12 to 18 months. In this setting, I'll check for kinase mutation, but not for somebody with a minimal disease, because this patient can expect to have a normal lifespan still.
Mm. Speaking of PCR, how do you see the role of digital PCR and maybe other ultra sensitive methods evolving for MRD detection and things like
I think
CML?
we moved away from PCR, sequencing PCR at 20%. We're all using NGS today. with a sensitivity of 1% or less, which is even better because it allows us to tailor therapy in a better way. Because we know with the Sanger PCR, having no mutation doesn't mean you don't have any. And NGS allow us de- to detect these mutations that can help us tailoring our next line of therapy, and that's very important.
Mm. How close do you think we are to using things like genomic instability markers to guide maybe frontline therapy?
I think we're doing so well in frontline therapy. I think what dictate our choice of frontline therapies are the price of the medicine, the goal of therapy, be it survival only, because if you're aiming for survival, all TKIs are identical regardless of genomics, or TFR, mean inducing treatment-free remission. Patient comorbidities, because each drug has its own side effect. And finally, the risk score of the disease, high tumor burden, low tumor burden. I think where genomic instability play a role is more in blast phase disease, or advanced stage disease, where progress has not been at a level seen in chronic phase.
Mm. And as far as high risk genomic features, should early intervention strategies differ in patients with high risk genomic
We
features?
do not know today in a chronic phase. For example, when we perform NGS sequencing on this patient with CNXL1 mutation, this patient have more cytopenias, but they respond. And some people are recommending transplant to these patients. The data is controversial and still not so solid. I think today in 2025, I will not make a treatment decision in a chronic phase based on these findings. We need more data and more evidence.
Mm. You spoke a little bit about molecular milestones and just thinking about precision medicine. What do you consider the most critical for guiding therapy changes in CML? Like, how frequently do you recommend monitoring? Um,
So when it comes to monitoring, I think it's very important at the beginning to do it closely every 3 months. And the reason behind it is not only to identify the milestones, but make sure patients are compliant, because patients may not be compliant, and this monitoring will tell us if people are doing well or not. I will do every 3 months at the beginning by peripheral blood testing for PCR and fish testing. After once patient fish is negative or PCR is 1% or less, I will solely follow on a PCR.
mm,
I do it every 3 months till I reach what we call the MMR or T log reductions. After that, I can space it out to 3 to 6 months for the next year, and then every 6 months thereafter.
mhm. We spoke a little bit earlier about how, the good news is that people can live a normal lifespan with some of these with CML. So I'm wondering, how do you currently stratify patients for first line TKI selection in particularly in younger patients seeking things like treatment free
I
remission?
think for younger patients who are seeking treatment remission, I'll give an example: a woman who eventually wants to conceive a day. I do favor the drug that can induce deeper responses faster, like second gen TKI or even a asciminib today, approved in the frontline. However, I will pay particular attention to the price, because even though second gen TKI can induce faster, deeper responses, still the price does not justify this intervention. No, the dasatinib is available to us today at a generic price, and I hope other drugs will follow as well. I think, yes, in absolute way, young patient where I aim to stop therapy, I do favor a second gen TKI or even a asciminib, but price is something to be taken into account as well.
Okay, so yeah, with that in mind, what strategies you mentioned second gen TKIs? What strategies do you advocate for when it comes to balancing cost effectiveness with the need for individualized mutation driven TKI
Well,
selection?
as I said to you, in the frontline, there's no mutation driven. So frontline, we don't take into account the things. Frontline, we go for the data we have. I do favor the absolute way the second gen TKI or a asciminib if my goal is to stop therapy in younger patient. But price remains an issue for the American population and worldwide, and more so in American population. I think for new drugs to be justified to be prescribed with the aim to induce treatment-free remission should not go more than $40,000 to $50,000 per year of treatment to be justified for the aim of stopping. But that is beyond my control at this stage.
Mm. And then are there resources what resources do you recommend to patients when, let's say, their insurance is not necessarily cooperating or they reach like a price ceiling or something like that?
Well, we have patient advocacy groups. We have coupons or copay from pharmaceutical companies to help their patients. I can tell you, for example, when we start a treatment like a asciminib, Novartis providing free drugs at the beginning. So there's ways to get things done. But in a setting of generics being available, it still remains hard to justify new drugs. When you have a drug like imatinib costing $400 per year, it's hard to go for other drugs.
Mm. Some of your recent work reported successful treatment-free remission after ponatinib and discontinuation in pretreated CML patients. What criteria should guide clinicians in considering TKI discontinuation, and maybe what are the risks of relapse in these scenarios?
Well, let me differentiate here. When you consider stopping TKI in the second line, third line, I think the success is mainly seen in patients who are intolerant to first line of drug. Means if somebody had resistance to first line drug and getting a second line, I'd be reluctant to consider stopping therapy. It's more the TFR is more successful when you have an intolerance. No, that being said, whether in the front line or relapse or the second line and you want to consider treatment for remission, you must aim for a deep molecular remission sustained for a bit. I know the guidelines recommend 2 or 3 years. In our experience, we've shown that if you have 5 years of deep response and you stop, your success rate goes up to 80% and even higher. Something was around 40 to 50% if you do 3 years. So the longer you stay, the longer your response is, higher is the likelihood of stopping and remaining free of the disease.
And are there any other key predictors of successful remission off?
The only one today that seems to be predicting is the duration of deep molecular remission, not the drug, not anything else.
Yeah. So your JAMA Oncology review highlights the rapid evolution of ALL management with combinations of TKIs and immunotherapy replacing prolonged chemotherapy. What are the practical implications for frontline therapy selection?
You know, stopping therapy is very important because it's important for the patients from the compliance, adverse event and outcome, and financial. I mean, copay for lifetime is something can be a big burden. However, we have not been successful yet to identify the best strategy to stop treatment, except giving the drug for as long as possible and be able to induce a deep response and stop after 5 years. But what we aim to do is maybe if we combine the TKI with other drugs, then we don't have to wait too long to stop. And then when we stop, the success rate is higher. And we use rationale from the lab medicine, such as laboratories data of in vitro data, for example, combination of BCL2 inhibitor and TKI, HMA and TKI. But in all honesty today, we have not been successful. We are trying, we need longer follow-up, and we have not seen the combination can improve the response rate, can improve the depth of the response, the ratio of response, and the TFR as such. There's some data on JAK2 inhibitors, but still the data is not solid enough.
Do you have any ideas on how you see this evolving in the next 2 years, in the next few years?
Well, I want to see a drug or a combination inducing a higher rate of sustained molecular remission. I think if you can meet this endpoint, then you can successfully stop the treatment and win. This is what we're doing right now, and still we're on our way.
So, what are some of your thoughts on how monoclonal antibodies are kind of changing the landscape for adult ALL, and what are some of your main challenges and opportunities in integrating them?
I think in ALL, it has been a success story as well, like in CML. Not so as much as CML, but we're very close. And this is because of the immunotherapy platform we have that's being integrated into the frontline setting. And that have shown that such a strategy improves survival. And then as a consequence, we're using less of intensive chemotherapy, less of a complication, and improving survival and relying less on transplant. Because by deepening the responses, we use less transplant and that correlates with a better outcome. The challenge is still like expensive and we need to have a full penetration. I think we're doing quite well in USA, but I hope worldwide we will have the same results too.
And you've also mentioned things like multi-targeted antibodies and CAR T therapies as future directions. What are some of the most promising candidates currently, do you think, in trial, and what hurdles maybe remain for their broader adoption in adult ALL?
Well, ALL is rare disease, and I think to get a standard of care, you need to have a randomized trial. And I think it's not the right time to conduct randomized trial. The field is evolving so fast that if by the time you complete a study, your new standard will become obsolete. So I think as investigators, we need to be smarter and maybe single arm trial, small series, and try to keep improving till we get to the optimal regimen we can have, and then we can randomize our patient. I think in a setting of immunotherapy, what I've seen, that physicians use one drug at a time. Yes, you can have some responses, but not too durable. So if you look at the investment done with one drug at a time, you have minimal return and a lot of money spent. In contrast, if these strategies are being used in combination and upfront, you can have a better responses, better outcome, and a better safety. So this is what we're doing today.
So you've addressed the impact of achieving MRD negativity after CAR T cell therapy in B-cell ALL. Based on your, I would say, latest finding, although I know there have been many papers, how do you think MRD status should influence post-CAR T management, particularly regarding the need for allogeneic transplant?
Okay, number one, I like to usually put my best effort in the front line. I will not wait for relapse. I think using immunotherapy up front and having an MRD negativity is good for the outcome. And by MRD negativity, I mean going deeper and deeper. For example, today we're using the NGS testing at 10 to minus 6 means patient on a flow studies who are negative, we know 40% of them remain MRD positive. And only if you become MRD negative by NGS, then you will do well. The question is, does that satisfy us or transplant is still needed? I think not all patients are equal. And I think NGS MRD negativity is great, but not so great in everybody because some patients have a very poor biology, like KMT2A disease, where transplant is still needed. Now, that being said, I think the strategy for us today is, can we get CAR T cells into the front line? Where? I think the future of ALL is for the CAR T to replace allotransplant because today, despite the immunotherapy we're using, high-risk patients are going for transplant, and when they relapse, they go for CAR T cells. What I want to do is and evaluate whether CAR T can be given upfront and spare the need for transplant. So you take a patient at high-risk disease who get the inotuzumab, blinatumomab, they go into remission and go for CAR T. This will allow us, if we can demonstrate that it's feasible and successful, to transform treatment for ALL from 3 years to 6 months, with the CAR T being a finite therapy as a consolidation post short induction consolidation. That's what we're testing today. And I think if we're successful, we will cure the vast majority of the patient with a short period of time.
So you've detailed the approval of 12 new agents for AML since around 2017, including menin inhibitors and CD123 target therapies. Which of these agents are most likely to reshape frontline therapy, do you think, and for which molecular subgroup?
I mean, in AML, we have a lot of approval, and actually, I'm glad to see the menin inhibitors filling an unmet need. The FLT3 inhibitors, among others, IDH inhibitors, BCL2 inhibitors. However, I think the success is in the front line. The success is our capability to integrate these target agents into the front line. For example, today, if you look at the FLT3 ITD AML, where used to be a disease with a very poor outcome, if you integrate FLT3 inhibitors up front, if you go for transplant and you do maintenance post-transplant, you can improve the cure rate to 70-80%, what historically used to be very low. The menin inhibitors, it's a horrible disease, but today, yes, they're effective in a relapse setting, but that is not what we want to accomplish. It's good, but we want to move this in combination of frontline to hopefully improve the outcome of these patients. Still, there's some work to go among them. For example, the MECOM AML, they do not do so well. The TP3 positive AML, these are we lacking. We need drugs for these patients, but I think overall we're making progress.
So when it comes to triple therapy regimens in AML, what have interim results shown regarding efficacy and safety, and how close do you think we are to changing the standard of care for newly diagnosed or relapsed?
I give you an example of triple therapy is a FLT3 ITD AML, where we're using, for example, most of them are older unfit. We're using HMA as a backbone and venetoclax and adding FLT3 inhibitors. I think what we need to learn is how to manage these two drugs together because there's a price to pay for safety. That is still work in progress. I think we need to rely less on a venetoclax, be very anticipate change of dose and duration of therapy, but then having good testing to assess for MRD. And maybe, as we did in ALL, those who respond well and become MRD negative may not need a transplant to be done down the road. This is work in progress, and I think this is where we're heading. I think triplet is feasible, even quadruplet, but one should be very careful with the amount of drug given, of each drug given, in order to deliver a safe regimen.
Are there any additional promising areas of research that you're looking forward to exploring on your own or seeing explored in the field in general?
I think one day they asked President Obama when is the best time to be, and his answer was today. I'm fortunate to be in a time where we have the tools to cure, for example, ALL. I think we're moving away from the chemotherapy, the length of therapy, the complications, to short chemotherapy-free or less chemotherapy with the integration of immunotherapy. And if we're able to demonstrate that we can integrate immunotherapy and CAR T upfront, we can cure this disease. And this is not only for patients who have the privilege to come to MD Anderson, but for the whole nation and the whole world. So short time of treatment of immunotherapy CAR T, let's say 6 months of treatment given. Now we're testing this concept in Houston, and the next step will be to expand to Texas, the USA, and the world. And I think we can cure leukemia in our lifetime. That's in ALL. In AML, major progress done, mainly in younger patients and less so in older, but we're heading toward the same direction. In CML, it's curable, and so CLL. So I think we made amazing progress, and we can tell our children and grandchildren we cure this disease in our lifetime.
Yeah, that's exciting news. Which patient populations remain underserved by current therapies, and how is the field addressing the needs of older adults with leukemia, and who often have worse outcomes?
I mean, the worst outcome remain in older people, as you said, AML, ALL, MDS. I think in ALL we're making better than AML and better than MDS. Still, we need to come up with new strategies, innovative medicine, and have access to these people, because a lot of them, they don't have access to great care. I think we need to make what we do here available to all the people.
Yeah, speaking of availability, I want to talk a little bit about artificial intelligence, machine learning driven analytics or digital health tools. How do you feel like that can be integrated into the management of CML, especially for things like early detection or of resistance or relapse?
I think AI will have a major place in medicine, as it is in different things. At least it can get me the data available, identify things that we can miss. For example, when you do X-rays, imagery, and others. And I think it will be complementary. I'm not concerned that it will replace us, but it will help us delivering a better medicine.
One thing that we've heard a lot is the use of machine learning to analyze previous clinical trials and data from previous clinical trials. And there's also these conversations about insights being found across specialties and things like that. Are you thinking at all, or is there conversation in the field about how data might be kind of set up in order to think about how it could be analyzed in the future by artificial intelligence?
Of course. When you set the expectation what you have, you can predict the future, correct? So definitely this will be a major tool.
So let's talk about the patients for a little bit, just from a patient perspective. For patients and families facing a diagnosis of leukemia, what advice would you give regarding new treatment options and things like clinical trials?
Leukemia is a rare disease. I think for anybody affected by leukemia, which is not something great, there's tools to cure leukemias, and I urge them to reach out to Center of Excellence, at least for second opinion, if not treatment.
What does the approach look like from a multidisciplinary perspective? Do you think there needs to be more multidisciplinary approach to patients with CML, or are there gaps?
Of course, we practice with our colleagues. I gave an example in CML when we look at the toxicity of certain TKIs and mainly cardiac. I fortunate to work at a place where I can have access to my colleagues who are in cardio-oncology and others. So yes, we don't practice by ourselves, and I think we're open for communication. And you mentioned the AI, like we're not anymore alone. So we are part of a whole global body, and I think we should take advantage of it.
When it comes to communicating with patients, both the state of their disease and their options, where do you see gaps in patient communication, or what are some maybe possible misconceptions that patients often have that might impact their decision-making process?
One thing that the patient is sometimes they're shy of asking questions, or they feel like, oh, I should not bother the doctor or whatever. I think when I meet a patient, I tell them, you're my boss and I work for you, and I will do everything I can to help you. So just whatever you have in mind, feel free to ask, not today, tomorrow, anytime.
what would you see or hope to see as options for patients who maybe don't have access to hospitals that are as fortified as MD Anderson?
You know, this is a major problem in this country because we're so big and people may be 8, 9, 10 hours away from our center. This is why I think we need to come up with a new strategy that can be deliverable and easily to patient wherever they are. And that's why we're working in ALL and we're developing a regimen that can be applicable anywhere, short and simple to improve the outcome.
Mm. What do you think are some of the biggest gaps to having more people participate in clinical trials? Because we always hear about clinical trials, maybe.
There's always logistical issues, distance, travel. Like if I have a trial in Houston here, I can cover the trial, the drugs, and everything else. But patients still have to drive, to travel, to live in a hotel, to rent an apartment, and these are all expensive. They're not covered by insurance or anybody else. I think we need to make the medicine more affordable to our patients. And by medicine, I mean everything that comes with it.
Sounds great. Do you have any parting words for your fellow physicians in the field that might be maybe working at hospitals that aren't as fortified or have access to?
I will tell my colleagues we are in the best time when I cure this disease. I'm available anytime. Please reach out. Happy to help in any way I can.
Well, thank you so much for joining us on MD Newsline. It's been an absolute pleasure.